I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, so we are going to kick off the respiratory section with asthma. All right, so first off, there's two major respiratory conditions that require the use or can require the use of medications. So we've got asthma and COPD, and I just wanted to give you guys a rundown of the differences a little bit between those two respiratory diseases. I think it's good for the background and the understanding. Asthma is more of a reactive disease, meaning that the airway is much more reactive. It closes and opens based upon triggers and those type of things. It's a younger onset. It is more easily reversible than COPD. Patients will present with wheezing in asthma typically compared to COPD. And the big thing from a medication standpoint is asthma is always considered to have an inflammatory component to it, and that is, one of the big reasons why we use inhaled corticosteroids. They are the medications that really blunt that inflammation of the disease. So really important there to remember that. And with asthma, I alluded to those triggers that may induce or help promote an asthma attack, which obviously isn't good. Cold air, exercise, any type of infection, environmental allergies. Certain times of the year, patients can have more asthma attacks in the fall or, those type of things. GERD is associated with increasing that risk, and then there are certain medications. So I'll refer you back to the beta blockers section in the cardiovascular section if you don't remember much about those and how they can potentially affect asthma and asthma medications. All right, so factors in classification of asthma. We're going to look at the frequency of exacerbations and particularly frequency of exacerbations that require oral steroids. That's not good. That's indicative of a patient that's not in control. Rescue inhaler use. How often are we using an inhaled corticosteroid and a short-acting beta agonist or a beta agonist in general on an as-needed basis? Does it impact the patient's daily life? Very important to pay attention to that. Nighttime awakenings. And FEV is forced expiratory volume, sometimes called peak flow. It's basically a measure of how much air a patient can blow out. So how much restriction is there? That number will go lower and lower and lower. So the worse the exacerbation is. All right, there's a rule of 2 in asthma. Maybe you've heard this, maybe you haven't. It's a good kind of gauge of how well controlled your patient is, and this is a great thing to report to the primary provider if the patient reports this. Okay, so ideally, we want less than 2 times per week of the use of the PRN or as-needed albuterol and other medications to acutely help breathing. Nighttime awakenings, we want less than 2 of those, ideally. 2 refills per year on rescue. So probably more of a pharmacy thing here, but if you know that your patient you're working in a clinic, let's say, and the patient's calling in refills all the time for their acute reliever of their asthma symptoms, that's pretty good indication that things are probably not that well controlled. And then, of course, any ER visits, hospitalizations with the primary diagnosis being asthma, that's going to be concerning, of course. Another kind of assessment is the asthma control test. Basically assessing the patient's symptoms here. I'm not going to go through all of these. I think they're good for you to read through to understand some ideas and some things and some issues that patients run into as far as their asthma control. And there is a scoring system based upon that. We want a higher score in that ACT scoring. So if you see that score reported, that can help us kind of identify like, oh, geez, this patient's at a 10. They're got pretty poor control of their asthma right now. We need to really pay attention to this. Maybe we do some education on inhaler use and what it's for and those type of things as well. Asthma action plan. This can help guide patients when they're not maybe in a clinic or in a healthcare situation. It delineates green, yellow, and red zones for asthma care based upon peak flow meter. So peak flow meter is kind of a kazoo-looking device. It's a small, little device. It's probably in the neighborhood of 4 to 8 inches long. And this can help us assess how good that patient's respiratory function is at home or, away from the clinic, away from the hospital. So it gives the patient specific actions to take if they're outside certain zones with that peak flow meter. And here's a sample of what that looks like. You can see the green, yellow, red zone. The provider can fill this out and give that guidance. So, if you've got a patient calling in saying they're having, difficulty breathing, obviously you want to assess that patient. Might not be a bad idea to ask if they have an asthma action plan and if they have incorporated it, if they've checked it, where they're at with that. Okay. Some patients might have it, but obviously if you see in the medical record that they do have one, hopefully they can give you this information and, follow that asthma action plan accordingly. All right, so let's start to get into the medications. So we've got inhaled corticosteroids. Remember, I said inflammation is huge in asthma. We need to get that under control in asthma patients. And so mechanistically, corticosteroids, they stimulate glucocorticoid receptors in the respiratory tract, and this suppresses inflammation, which can ultimately help improve breathing. Now, we can give systemic corticosteroids too, but we really try not to do that. We want the localized effects. We don't want all the other systemic adverse effects that go along with corticosteroids. And some of those, longer-term risks or, chronic problems with systemic corticosteroids involve osteoporosis, HPA suppression, elevations in blood sugar, so hyperglycemia. So there's lots of problems with, utilizing systemic corticosteroids frequently, okay? And so we really try to do that. We try to avoid systemic corticosteroids, but, in the case of a severe exacerbation, those type of things, we may not get away from that, unfortunately. So some examples, budesonide, Pulmicort brand name. It does come as a nebulizer for that one. Beclomethasone, fluticasone, mometasone. These are all inhaled corticosteroids. Now, keep in mind, and I've got slides coming up here, there's combination agents, which is most commonly used in asthma. Usually we just don't use, one inhaler as the corticosteroid and then one inhaler as the long-acting beta agonist. We usually use combination medications because obviously it improves adherence and convenience and all that good stuff. Inhaled corticosteroids do take a little time to work, which is why in an acute exacerbation, we will likely use an inhaled corticosteroid, but we will also combine it with a beta agonist that has a quick onset and can open up that airway quickly. Okay, so that's an important thing there. Patient education point, huge, very important. Inhaled corticosteroids can increase the risk of thrush. So that is a fungal infection in the mouth. So patient education, we need to rinse the mouth with water and spit following use. Okay, very, very important to remember that. Okay, next class, we've got short-acting beta agonists. So remember, in my discussion on beta blockers and beta receptors, those type of things, I did talk about beta-2 receptors. So short-acting beta agonists and long-acting beta agonists, they stimulate, or they are an agonist on beta-2 receptors that relaxes smooth muscle in the airway, and it opens up that airway. So obviously that improves a patient's breathing. Common names, albuterol and levoalbuterol. Albuterol is definitely the most common short-acting beta agonist. Brand names, ProAir and Ventolin, probably the two most common brand names I see thrown around. So these work quickly, within a couple of minutes, and, are meant to help acutely in an acute exacerbation. We obviously want to get that inhaled corticosteroid on board too and get that inflammation down. But if a patient experiences some relief, which obviously hopefully they do, and that's what our goal is, with a short-acting beta agonist, that's the acute relief. It's generally not the inhaled corticosteroid that's helping them breathe within a few minutes. It's the beta agonist piece of that. Now remember, if you remember beta 1 and beta 2, so beta 1 was on the heart. So if we give a lot of albuterol, or if a patient's just a little bit more sensitive to it, we may affect those beta 1 receptors. And if we do that, if we stimulate beta 1 receptors, we can impact the heart rate. So we can cause some tachycardia. It can amp you up a little bit, can cause some anxiety, some tremor, some shakiness. So those are important things to monitor if we're giving these medications to make sure that we're not giving too much. Rarely there is the potential impact of lowering potassium levels. Generally not something I'm too concerned about. With an acute relief inhaler that's not used terribly often. But if you've got a patient that's maybe excessively using it, or close to overdose type of things, it may be clinically significant and bring down that potassium level too far. So something to keep an eye on, but generally not something that happens crazy often in clinical practice. All right, so monitoring this short-acting beta agonist use is very important. It's a good indicator of how stable we feel patients are with their asthma if they're using this medication. All right, now we've got long-acting beta agonist. That term's a little bit not accurate, maybe. So in general, they are long-acting, but they also can work quickly. Okay, and budesonide formoterol combination, formoterol works pretty quickly. It's got a quicker onset than some of the other longer acting agents. So this medication, you could potentially see this used on an as needed basis in combination with budesonide or another inhaled corticosteroid. Okay, so typically long acting beta agonists weren't considered to be quick enough to do that, but formoterol has been proven to be quick enough to provide that acute relief in asthma. So the big differentiating factor between long-acting and short-acting beta agonists are probably as it sounds. These drugs will last longer. That's pretty much the difference. Versus albuterol needs to be redosed fairly frequently. Long-acting beta agonists, tend to last 12 to 24 hours. Okay, so again, can vary a little bit depending upon the specific agent, but again, longer acting agents. Identical adverse effect profile to the short-acting beta agonist. So that's hopefully easy to remember for you. Remember, if we get too much, we can stimulate that beta-1 receptor and cause those cardiovascular concerns where we increase that heart rate, and also can amp up the patient, cause that shakiness, tremor, anxiety, those type of things. One last thing I did want to mention, using a long-acting beta agonist in asthma alone without an inhaled corticosteroid, there is a black box warning against that. Okay, so it can increase the risk of death, which is why we often use, or pretty much always use just about, an inhaled corticosteroid with a long-acting beta agonist, and that's why they come as combination medications. And these are maybe ones you're more familiar with. Advair, for example, there. Airduo, maybe you've heard of. Symbicort, you've probably heard of as well if you've been out in the real world a little bit. I will say budesonide formoterol, Symbicort, or formoterol in general, I guess, but Symbicort's the one with the most recent evidence, or best evidence recently, indicating that we can use that on an as-needed basis for an acute relief of an asthma exacerbation. So historically that wasn't the case, but now we have evidence to say that can be utilized on an as-needed basis. All right, so steps in asthma treatment. So intermittent guidelines just recommend as-needed inhaled corticosteroid with that beta agonist. And most often that's probably going to be Symbicort, where it's just one medication in one inhaler device. As we go up the scale of more severe asthma, mild persistent, generally we're going to take a low-dose inhaled corticosteroid on a chronic basis, and then plus the additional PRN steroid and beta agonist. As we go up the scale, we raise that dose of the inhaled corticosteroid on a regular routine basis, and then we may add a long-acting beta agonist as well. So that's kind of how we go up the scale, and then obviously the severest case we add high-dose inhaled corticosteroids plus long-acting beta agonists on a routine basis. We may also consider montelukast, and then there are some other more obscure, rare type medications. I'm not going to go into them into any sort of serious detail here. Generally more specialized, that type of thing. But keep in mind, if we ever need something as needed in that acute exacerbation type of situation, we're going more and more towards the combination of the inhaled corticosteroid, and we got to have that beta agonist for that acute relief of respiratory distress. I did want to mention acute exacerbation. I alluded to the fact that we do use systemic steroids for exacerbations. Usual adult dose is in the range of 40 to 60 milligrams. Usually we're using prednisone. Keep in mind, prednisone can cause some adverse effects, of course. Most of the time, GI upset. That's probably a really, really common adverse effect with prednisone. The other big thing is it can really amp people up. It can cause some anxiety as well as insomnia. And so we like to dose that prednisone, if we can, a little bit earlier in the day. For prednisolone, we've got some dosing there for pediatric patients. And again, kind of that target is usually no more than 10 days, 10 to 14 days of treatment for an acute exacerbation. Okay, so we want to try to minimize the length of that steroid, and that helps reduce the risk for HPA suppression, as well as some of those chronic or longer term steroid adverse effects. Nebulizers, I did want to mention this specifically. So sometimes patients can have a lot of difficulty navigating, dry powder inhalers or aerosolized inhalers, coordinating the movements, coordinating their breathing, and most commonly that's pediatrics and geriatrics. Okay, so There's lots of medications that come in nebulizers, albuterol. We've got long-acting beta agonists as well. We've got inhaled corticosteroids. We've got an anticholinergic medication as well, which isn't used terribly often in asthma. But we do have options. So if you've got a patient that you don't think is getting that medication because you don't think their technique is appropriate or correct, that's definitely a good patient education point, as well as potentially, notifying the pharmacy, notifying the primary care provider, saying, hey, can we switch this to something else? That's definitely a good question to ask if you feel like the patient is really struggling to utilize their inhaler. All right, and then overall, nurse monitoring in asthma, respiratory rate, that's probably a no-brainer. We're looking at breathing there. Heart rate, so again, tachycardia is common in distress or with those beta agonists, whether that be albuterol or even long-acting beta agonist if it's being used more frequently than we'd like. Blood pressure can go up a little bit, change. Pay attention to that. Oxygen saturation. Usually that's going to be pretty good in a patient that's got good asthma control, but in an exacerbation, that's potentially going to start to drop there. How difficult does it look? So basically, clinical monitoring of those patients. How hard are they working to breathe? Are they using other muscles than just kind of the ones right around their respiratory tract? Are they able to talk to you without having to stop and catch their breath? So are they able to, get up, walk around, move from the chair, to the couch, whatever the case may be? So identifying some of those issues and monitoring them clinically and seeing if they're able to do what they used to be able to do and how far off they are on that. Peak expiratory flow rate, if available, compare with the patient's best. Inhaler device technique and education, super, super important that you pay attention to that you monitor for that, and give that appropriate education as needed. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse.